Okay, good morning. It is now April 27th, 2023, and I'm Dr. Duke Majan at the Duke Spine Institute. We're going to be fixing a gentleman's lower back. He's had back pain and left leg symptoms now for a while. The back pain he's had for years. I'm trying to find the right place to go in. And I've already numbed this area up for him. Just lay still, you're fine. Are you comfortable?
Yes.
All right, let's give some more numbing medicine. So back pain for how many years? We said 6 years? And we're going to be sharing the surgery with you all, viewers, so you can watch and ask questions during the surgery, as we do for all of our surgeries. Okay, you can see I'm aiming for the L3-S1 disc space. All right, let's take another picture, see what we've got. All right, we are way off on orbit. I think maybe he's moved a little bit. You see the orbital problem? And shot. So the orbit, what I'm looking at is the back of the vertebral body of L5. Still off, I think. I mean, I don't know how much we're off. You see the two rabbit ears sticking up? So before I go any further, we have to get the alignment. That's better. Actually, that's really good. Show us where we're looking at so the audience can see. So for WAG, we're going to look at the disc space. Show us the disc space. That's the disc space. We want to be looking straight down the disc space. And then we want to look at the pedicle. Show us the pedicle. The pedicle is right where the arrow is, but show us the top of the pedicle, the top line, the black line. Just trace it for us. Yeah, that's the top of the pedicle, and show us the bottom of the pedicle. Yep, there's a bottom. And there's two pedicles, left and right. So if you're shooting through perfectly, you're going to see the pedicles superimposed on each other, and that's what you're looking for. And then show it, wait, stay there. Show us the back of the top of the vertebral body, okay? So that's the top there, and show us the top of the other side. You can barely see it, just a little lower. Down, nope, left, left, left. A little more, right there. You just passed it. Just there. That's the top of the other side, okay? So if your orbit is off, then those tops of backs of the vertebral body are going to be off. So I'm looking at those for my orbit, and I'm looking at the pedicle and the disc space for WAG. So far, not too bad. I may want to start a little bit higher, I think, than I am. A little bit higher. Okay? And that's why we have to do the x-ray. It has to be perfect before you actually start figuring out where you're going to go. If you don't have reliable navigational information, you shouldn't start on your trip. Otherwise, you're just wasting time and gas and resources, right? So you got to know where you're going and from where you're starting so you can plan out a route. All right, so we're heading for L3-S1. I can feel the facet. I want to be a little bit more north. You're doing great. Just relax. Everything's okay. Shot. It's too high. So I'm going to redirect. Still too high. I want to redirect just a little bit south. Shot. Shot. All right. So I want to be a little bit lower with my tip. Shot. Seems to be quite a bit of scar tissue here. Shot. And he does have a high iliac crest, by the way, which I'm having to get around. Shot. Where do you feel that? In your back?
He said yes.
All right, that's where we want you to feel it, not your leg.
It's not traveling down your leg, right?
Shot.
Only your back. Okay.
All right, good. Where do you feel it? Your back? Just look. AP. All right, so that's perfect. By the way, for those of you who have not watched these surgeries before, the L3-S1 bottom disc in the spine is the hardest to get to with a transforaminal approach, which is why a lot of doctors won't even do it. They don't know how to do L3-S1. Endoscopic. So of the 10,000 spine surgeons worldwide, probably 10 of us know how to do L3-S1 endoscopic transforaminal at L3-S1.
Stay still.
You're doing great. Just lay still.
You're doing really well.
There's the facet. Getting around it. Shot. All right. So I'm pretty happy with that. Where do you feel it? In your back?
Are you feeling it in the back? Is it going down your leg? No.
Just the back.
I'll translate.
Perfect. Man, that couldn't be any better than it is. So, wow. Talk about a high iliac crest. So just so you understand what I'm talking about, in the back here, there's a bone called the iliac crest. Okay? And it's a bone that comes up like this. You guys all seen it on the skeleton, right? The skeletons have this pelvic bone called the iliac crest. And in some people, it's really high. That's just the way they're born. In other people, it's lower. So it's easier to get to 5-1. But look at the angle of this needle. I'm having to, instead of going like this, I'm going like that towards the butt. And I had to start super high, okay? But we're in. That's what matters. So now, why did I start with L3-S1? Because that's the hardest one to get into. And I have to change you saw me change my entry point, right? I started here, and then here, and then here, and then finally ended up here. So now that we've gotten into L3-S1, that sets my incision for the rest of the levels, because the other levels are easy to get into compared to L3-S1. So now we're going to make our incision. You're doing great. Everything's going well. You can tell that he was on some type of a blood thinner at some point because his blood is a little thin. It's almost like water, and that's fine. We're okay. Everything all right, guys?
My friend? I'm trying to get you a little more
All
comfortable.
right.
Is that better?
Yeah. Whatever he was on, I think he was on aspirin. Was he on aspirin at some point? Aleve, yeah. Yeah.
7 days ago?
Yeah. He may have quit 7 days ago, but the effects are still present. And that's fine. Shot? It's not bad. Just lay still, you're fine. That's your facet joint. So I'm getting around the facet joint. Shot. Just almost at L4-5. You can see he's got a listhesis. Everybody see that? Oh, Henry, I don't know if you could add it. It's too late, but he has a spondylolisthesis. It's probably too late. He has a spondylolisthesis at 4-5 as well. You guys see how the 4 is slipping on the 5? Forward. Jordan will show you. There's the back of 4, and there's the back of 5 is there. They don't line up. That's because 4 is slipping forward. A lot of surgeons will tell you need a fusion for that, but you don't. We don't need to do a fusion. We're going to fix his pain without a fusion. So now we're in at 4-5. That leaves one more disc to fix. And Jordan's going to readjust. Jordan is our x-ray technician. He's going to readjust. Well, actually, he's more than an x-ray tech, right? You're the laser guy, you're the endoscopy tech, the laser tech, and the fluoro tech.
Where's a lot of hats?
Right? So Jordan is adjusting the position of the x-ray machine, the fluoro. And by the way, this is our new fluoro machine we talked about a few weeks ago. We've invested in the top of the line, newest and best from Siemens, which is a German fluoro company. And we have a name for this one. It's Clyde. Yeah. So my diagnostic imaging team has named the fluoros Bonnie and Clyde. Don't ask me. But I named the X-ray, the laser machine, Chewy. So I got to name it Chewy, short for Chewbacca. Everybody knows Chewbacca, right? From Star Wars, shooting the laser everywhere. Huh? Right? Speaking of movies, I'm ashamed to say I was watching an old movie last night. that this pretty funny movie. Everybody remember Cheech and Chong from the 80s? All right, let's get an AP. So I'm in at 4.5, 5.1. I'm trying to get into 3.4 right now, and it looks like it's going to happen. But I feel like the facet joint is pushing me laterally, and I don't want to go lateral. So I need to check. It's not bad. I think we might be okay. Are you comfy?
You said yeah.
Yeah. So just a couple of comments. Number one, give me 1 second. Shot. By the way, a lot of what I do is by feel, in case you didn't know. Shot. Let's see on an AP where we are. And while we're doing that, notice there's no more bleeding. So his blood is definitely thinner than normal, I can tell, being a surgeon and seeing a lot of people bleed. But that blood is definitely thinner than normal, but you see he's still clotted. So basically, even though the blood's a little thin, he still was able to stop the bleeding by clotting off. All right, and that's what we would expect. And what made his blood thin was the fact that he takes Advil. Are you comfy?
Yes.
So when I talked to this gentleman in clinic, we did everybody thinks the MRI scan,
Keep your head still for me, okay?
the MRI, everyone thinks the MRI scan tells you where pain comes from, but it absolutely does not tell you where pain comes from. Stop looking at the MRI thinking you can figure out where pain comes from. You will never be able to do that. You'll be wrong 95% of the time. That doesn't mean we don't need an MRI. We still need the MRI, but you must do a physical exam. The physical exam is the key to understanding where people's pain's coming from. The MRI just helps, you know, with some information about structural abnormalities. So, for example, a perfectly normal disc will not cause pain. So if you have an MRI and it shows a perfectly normal disc, I mean, totally normal, you're not going to be having pain from that disc. On the other hand, if there's an annular tear and a small bulge, that could be very painful. So he's had pain for what we said, 6 years, right? 6 years back pain. And I asked him, where is your back pain? And when he showed me, he said it's in here. It's in this area here, okay? So basically, he was pointing at 3 discs to me. I know what's down there, 3 discs. L3-4, L4-5, and L5-S1. So I went and looked at his MRI, and sure enough, you guys can see it, those discs are abnormal. They're damaged. They're injured. So I knew that they could be causing his pain. Are you comfy? All right. Well, we're going to put you to sleep soon. Not yet, but soon. And are you excited to get rid of your pain? Have you thought about what you're going to do in life without back pain? Huh? Huh? What do you say? Hiking? All right. How bad is that on a scale of 1 to 10?
0 to 10, how bad?
What's the highest?
8.
No, come on. You almost came off the table. Don't be, it's not time to be heroic. What's the highest it went? 10 is the worst pain you've ever had. Huh? I can't hear him.
9.
9. All right, fine. Can you see it, Henry, when he like arched his back and almost came off the table?
A little bit, yeah.
Is that where you typically get pain?
Yes.
So the L5-S1, we always go with the highest number, by the way, when you do a discogram, which is what we're doing, an evocative discogram. It's a test. We have to do it anyway, so we might as well do it and get a number and record it. So he has a 9/10 pain at L5-S1, and it's concordant. You're doing great. We found one of your painful discs, by the way. I'm very happy about that. Is it better now? All right. Great. So it's better. Pain's gone? Yes, it is. Oh, really? How bad is that on a scale of 1 to 10? How high does it go? 9. 9. He said 9. 8 or 9. So again, 9 over 10, and that is L3-4. Is that where you typically get your back pain? Yes. So he has 9 over 10 pain. It's concordant, meaning that's where he typically gets his back pain at L3-4. Okay? So we have one more to test. That's L4-5. Is it better now? Yeah. So what we're doing, in case you don't know, folks, is I have to inject a dye in the disc anyway to do the surgery. And while I'm doing that, I'm recording his pain response, because a disc that is not painful for a person, you don't have any pain from a disc, if I inject it like I am now, it will not hurt you. It will be totally painless. So it's only a damaged disc that is inflamed and painful for the patient. That's the only kind of disc that elicits a pain response. And in his case, 2 out of the 3 so far have given him 9 out of 10 pain, and it's concordant, meaning that's where he typically gets his back pain. So this test is very helpful for us because it confirms that the back pain we're trying to cure is coming from those discs. Is it better? We're going to put you to sleep soon. By the way, that pain's going to be gone for the rest of your life. Isn't that going to be wonderful? All right. How bad is that on a scale of 1 to 10? What's the highest?
What number? 9?
All right. Let's show us 9 out of 10. Is that where you typically get pain? All right, so all 3 discs gave him 9 out of 10 pain, and it's concordant, meaning that's where he gets his pain every day. Jordan, show us, and Henry, go to the x-ray. You guys see this black thing right here? That is the dye within the L4-5 disc, okay? Folks, there's a spondylolisthesis at L4-5. We just tested the disc between the bones. The disc is what causes the pain, not the spondylolisthesis. So this is going to revolutionize spine surgery. Jordan, stay there. You guys see the tear where the white arrow is? Show us the tear. That whole thing is a tear. You see that, Henry?
Yes, we do.
That tear is the source of his back pain. Now move the arrow forward. There. That is not causing his back pain. Move it forward. That's not causing his back pain, but that's still part of the disc. It's only the back of the disc tear that causes the pain, and that was discovered at Duke Spine Institute. Okay? We're the first ones to publish it. It builds on work done by other doctors that taught me. Doctors like Cloward, Dr. Young, Dr. Rausching over in Norway. Okay? And these doctors have all gotten little breadcrumbs of clues, but nobody put it all together like we did at Duke Spine. And as a result, now that we know exactly where pain comes from, we can go in and repair that tear with a laser. And by the way, the laser debridement of the annular tear is the only way to get rid of the back pain. The only other way to get rid of it is to fuse the bones with a cage and screws and rods, which is a very major surgery, very high risk. This is a minor surgery done through a 7mm incision. By the way, we've lost now about 1 cc of blood. That's about 20 drops. Okay? So the surgery loses around 1 or 2 cc's of blood on average. That's nothing. If we did open back surgery, the fusion type for this gentleman, we would be most surgeons would lose 2,000 cc's, sorry. 2,000 shot. So we're losing 2, and open surgery would lose 2,000. A 3-level fusion, open. All right. We're now entering the L3-S1. Hold on. Let me see. Yeah. All right, we're good. We're entering the L3-S1 disc. This is the first disc we're going to fix. Look at this steep angle, folks. Go back and watch some of my other L3-S1s. The angle going from the head down to the tail is super steep on this patient because he's got a high iliac crest. That's what makes the surgery so difficult at L5-S1 to go transforaminal. And like I said, there's probably 5 surgeons worldwide that can do this surgery, transforaminal at 5-1. Most surgeons don't even try because they know they can't do it. But about 5 of us are able to do it. I don't even know the other 4. I'm just guessing. I don't know any surgeon that can do it besides me. That said, I do know from my training when I learned how to do the surgery that it was talked about extensively that other surgeons don't try L5-S1 transforaminal because it's so hard to get to. So what I'm saying to you is, not everybody can do this, okay? But we do it here at Duke Spine. Nice job, Luis. Not everybody has a Luis. We have the Luis. So, anyway. So what do surgeons do? There are surgeons that do 5-1 endoscopic, but they go here in the middle. And they go translaminar. They basically shave off the lamina and the ligament. They go around the nerve root. They basically destroy the spine in order to get to the herniation. We don't destroy the spine. We've done no damage to his spine whatsoever. We've preserved the spine. Somebody asked me the other day, does the surgery cause instability? No, the surgery cures instability. All right, let's go ahead and show our audience the educational video explaining why does a herniated disc or injured disc cause pain. What's the mechanism by which a disc injury, like an annular tear, was cause back pain and leg symptoms.
Traumatic injury to the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissues develop within the annular tear, causing back pain. The inflamed annular tear generates pain signals. Additional injuries can cause symptoms to worsen. Inflammation from the annular tear can spread to nearby nerve roots, causing leg pain. Signals travel up nerves to the brain, causing localized back pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of pain. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.dukespine.com.
Welcome back. Now you've seen our video explaining how does a disc injury, such as a herniated disc, bulging disc, ruptured disc, how does that disc injury cause so much back pain? And the answer is inflammation. No surprise there, huh? Inflammation, which is why people that have back pain take anti-inflammatories, because it's inflammation happening in a joint. And as a matter of fact, this patient, well, he was on Advil for a long time, taking Advil over the counter for his back. Of course, the medicine will never fix the inflammation problem. It just helps it for a little while. Medicines always have a temporary effect, and some medicines are very addicting. Let me have the grabber. So taking Advil, Motrin, Meloxicam, there's so many different anti-inflammatories, but all those medicines, they just don't fix the problem. So some doctors will give a powerful steroid medicine. They do what's called an epidural steroid injection. And what they're doing is they're adding a steroid medicine, which is a very powerful anti-inflammatory, to the area where the inflammation is happening. And guess what? People get better. They get better, but the problem is the steroid will never fix the back pain, because the steroid is not going to stop the inflammation. It only reduces it temporarily. Why? Because the source of inflammation, what's causing the inflammation, is not taken care of with a steroid shot. You're not getting rid of the source of inflammation. The Duke laser disc repair, the surgery you're watching right now, is the only surgery in the world that gets rid of the source of inflammation when you have a painful disc. That's why the Duke laser disc repair is so effective at fixing people's back pain and neck pain, because we're going after the source of inflammation, the disc. All right, let's show our audience, how does the Duke laser disc repair actually do its job? How does it work?
Disc herniations are a common cause of chronic back pain. The inflamed annular tear causes back pain. Inflammation of the nerve roots causes leg pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.dukespine.com.
Welcome back, and now you see through the animation exactly what the Duke laser disc repair does in the lower back and the thoracic spine both, to get rid of the pain from the inflammation. So we're actually eliminating the source of inflammation. That's what the Duke laser disc repair does. It's the inflammation that hurts, and by getting rid of the source of the inflammation, which is the annular tear with the herniated disc stuck in it. And that's the problem, is that most doctors don't know that. We've tried teaching it to them, but they don't listen. They're so invested in doing fusions, you know, because fusions pay more money. But fusions are far worse for patients. They're very dangerous and honestly completely unnecessary now. We live here in Orlando, Florida, and we work in Orlando, and I can tell you that the doctors in the area that are spine surgeons, all they tell patients about is fusions and artificial discs. They don't want patients knowing about the laser surgery because, well, quite honestly, they would probably lose a lot of money. I know I did. I started losing money when I started doing the laser procedures, but in the end, it's what's best for the patient, and it's less invasive, it's safer, and the results are better. So that's why we do it. It's better for the patient. It's not better for the surgeon. It's definitely better for the patient. Not better for the hospital, better for the patient. Not better for the companies that sell the screws and rods, but it's better for the patient. So unfortunately, most doctors make decisions, let me have the grabber, based on what's best for them, not what's best for the patient. I'm sorry to tell you that, but it's the truth. And it you know, medicine used to be a very noble profession where the doctors would always do what's best for the patient. You know, that's how we were brought up. That's how I was brought up. My father was that way with his patients. The Hippocratic Oath, as Dr. Berndes says. But unfortunately, over the last 20 or 30 years, things have changed. I need about another minute on this disc. I've done as much as I can. I'm trying to go as medial as I can. It's just some grunge in here, mostly scar tissue, but I think we got rid of the source of pain nicely. You can see this is a degenerated disc. It's very collapsed, but that's okay. You know, people think, oh, if the disc degenerated, I got to have a fusion. You don't. How many have I fixed? Too many. I can't even count them. Literally in the thousands of these degenerated discs with the laser. No fusion necessary, folks. None. You don't need a fusion. If you've been told you need a fusion, you don't. The only reason they're telling you need a fusion is that's all they know how to do. And if you go to a doctor who only knows how to do fusions, you're going to be in trouble because that's all they're going to recommend. But if you go to a surgeon like me who knows how to do fusions, who knows how to do artificial discs, who knows how to do laminectomy, discectomy, I can do all those spine surgeries. I could do them with my eyes closed, to be honest. That's how many I've done and how well trained I am. But I don't do them because they're bad for the patient. All right, we'll take our questions from the audience.
These two questions come from Chris DaCosta on YouTube. And the first question is, how much does this procedure cost?
How much does the procedure cost?
Correct.
It should be $1 million, but it's not, thank God. It's a lot cheaper than that. You know, for giving people their quality of life back and avoiding complications that happen with spine surgery so often. It really depends, Chris, on how many discs we're fixing and whether we're fixing them in your neck, your back, your thoracic. Every different body part requires different types of treatment. So the cheapest is a lumbar for back pain. That's what we're doing right now. That's the cheapest. But to know exactly what it would cost for you or anybody for that matter, we need to do an MRI review. That has to come first. So send us your MRI and fill out the questionnaire and we'll do a nice MRI review for free. And we'll let you know exactly what needs to be done, but also how much it will cost. All right? All done.
Lights on, please. Thank you.
Great question. Thank you for asking it.
We have another question.
I will say this in answer to the how much does it cost question. A lot less than a fusion. A lot less than an artificial disc. That's for sure. Since we're not putting any metal, it's cheaper. Right now we're using a little antiseptic to clean out the space that we just operated. Very standard for surgery. When surgeons are done with an area, they put some irrigation in, which is saline, sterile saline, and then they will sometimes use an irrigation that has some antibiotic in it. That way, if there's any, for some reason, if there's any bacteria that got in there, they can kill it, you know, thank you. They can kill the bacteria. So we don't expect there to be any bacteria in there, but it's a precaution we take, right? That's standard in surgery, is to do irrigation. Clean out the blood, clean out the debris, and just we like to put antibiotics in there. It's safe, better for the patient. There's a one-time type of antibiotic, and it's called betadine. It's developed by NASA, just down the road from us. We're literally 15 minutes from NASA. You can see the launches of the satellites when they go off just outside. We're in the Space Coast of Florida. All right, we'll take the question.
The next question from Chris on YouTube. They asked, does the spondylolisthesis or hypermobile vertebrae cause the disc to herniate?
Yeah, it's a great question. So Chris is asking, does the spondylolisthesis or hypermobile vertebrae cause the disc to herniate? First of all, the spondylolisthesis is not hypermobile. So that's a misinformation. What a listhesis is a slow movement of one disc on another. Would you consider a glacier to be hypermobile as it moves down a mountain? I would not. Glaciers are not hypermobile. But we call this glacial instability because it's a slow movement like a glacier moving down a mountain to the ocean, okay? So there's really no hypermobility at all. And the listhesis did not cause the herniation. The herniation may have actually contributed to the listhesis. So it's the other way around. The point is we're not fixing the listhesis here. We're going to fix the annular tear. And we're going to get rid of his pain by doing so. In other words, it's a fallacy to believe if you have a listhesis that you need a fusion surgery. You know, spine surgeons want you to believe that. Take it out. They want you, the patient, to believe. They'll show you your MRI and they'll say, look at those bones slipping. We call that a slip or listhesis. Oh my gosh, you need a fusion. But I can tell you right now, most spine surgeons now really they know the truth, which is that a fusion is not necessary with a listhesis. Now, here's the thing. If you're going to do an open decompression, you're going to open the back up, take all the bones and ligaments out in the back, called a laminectomy. If you're going to do that, then I would fuse. But there's no need to do a fusion itself unless you're going to open the patient up and destroy the back of their spine while you're trying to get to the stenosis or narrowing that's causing their symptoms. All right, come on out. Does that make sense? In other words, if you treat listhesis, if you treat the source of pain, which is the annular tear, with the Duke laser disc repair like we're doing right now, you don't need to do a stabilizing procedure like a fusion. The Duke laser disc repair is the stabilizing procedure. This is the stabilizing procedure. And for those of you that have a hard time understanding that, the instability we talk about in a spine, a lot of people don't understand what instability is. They think they know what it is, but they don't. Instability was first described by two orthopedic spine surgeons, White and Punjabi. And White and Punjabi defined spinal instability as extreme pain or the development of a neurological deficit such as weakness, numbness in the legs from pinched nerves in the back that comes with normal physiological loads, meaning just normal everyday standing, walking things that you do, okay? That's what spinal instability is. So it's two parts. It's either the development of neurological sequela or the development of back pain. And in this patient's case, he has both. He has leg weakness, numbness, and he has back pain. So we're going to go in there and we're going to clean up his herniation, but we're not going to treat his listhesis. And while we're doing this, we're going to get rid of his back pain. So other surgeons would have you believe that the listhesis is the cause of the back pain, but it's not, because we're leaving the listhesis alone, and we're going to get rid of his back pain. You'll see. We've done it thousands of times. I used to believe that spondylolisthesis was the cause of back pain. I used to tell my patients that, because that's what I was taught by my attendings, my faculty, the people that taught me. That's what we all believed to be true. And then I went out and I started doing these surgeries on people with spondylolisthesis. They refused fusions. I told them, you need a fusion. Your bones are slipping. You need a fusion. They said, nope, don't want a fusion. Give me the laser. And I said, but it won't work. And they said, I don't care. Do it anyway. I don't want a fusion. And I said, okay. And I did it. And lo and behold, their pain went away. And it stayed away. And then I started to say, wow, maybe they don't need a fusion. And guess what? After doing hundreds and hundreds and hundreds of these cases with listhesis and getting rid of their back pain without fusing and not without opening them, just doing the DLDR, Duke laser disc repair you're watching, I realized that it wasn't the listhesis that was the problem. And by the way, a lot of doctors know that too. It's not just me. They know that you don't have to fuse a listhesis. So you'll see that among spine surgeons, there's a huge division today in 2023 that many of them say fuse and many of them say don't fuse. But my personal opinion, if you're going to have an open surgery like a laminectomy to treat your stenosis from the listhesis, which is stenosis is narrowing, by the way, as the listhesis progresses, you can get pinched nerves, all right? And the pinched nerves cause neurogenic claudication, leg pain, weakness, numbness, tingling. So if you're going to go in and unpinch those nerves, you're going to have to take a lot of that normal bone and ligament out if you don't know how to do the Duke laser disc repair, this procedure. So if this procedure is not an option, you have to go in and do an open laminectomy. There's a piece of herniation, by the way. And if you're doing an open laminectomy, you are going to destabilize the spine more. You're going to destabilize the spine with your surgery. So if you're going to destabilize the spine with your surgery while you're doing an open laminectomy or discectomy, then guess what? You've got to fuse. Okay? You got to fuse. So I would agree with fusion in patients that have a listhesis, but only if they're having an open back surgery, which I'm not recommending for anybody anymore. Make sense? A lot of herniation here. It's more recent. This disc you can see from the white annulus and the blue nucleus pulposus that's degenerated. You can see it's a more recent injury. How old is our patient here? Huh? 74 years old. So this disc is a very nice disc, by the way. It's very recent, very recently injured. So the symptoms from this disc are newer. Like the last disc we did at 5-1 was very degenerated, right? Well, that degenerated disc doesn't look like this disc, did it? Go back and hit rewind. You can see this disc looks totally different. You see that white stuff? That's pretty fresh annulus, like nice healthy annulus. And the blue stuff is the herniation, and the herniation looks to me like it's more recent. It's newer. Look at the tear right there in the annulus. You guys see the tear? That's a perfect annular tear. Left side annulus, right side annulus. You guys see this? Annulus, annulus, that should be connected. All white across, but you see there's a tear in the middle. It's obvious, right? Luis? Yeah. So the blue stuff stuck in the tear is nucleus pulposus, the jelly. And that's what's keeping the tear from healing on its own. And that's what I'm cleaning out with the Duke laser disc repair. There's no other surgery in the world that does this. We discovered this technique at Duke Spine, and we're the first to do it. And it requires a laser. So if you're doing endoscopic spine surgery and you're not using a laser, forget it. You're already doing the wrong surgery, 100%. If you watch all my surgeries for the last 17 years, almost 20 years now, with the Duke laser disc repair, they all look the same. I'm doing exactly the same thing. It's called an annular debridement. I'm taking the scar tissue and the nucleus and the inflammatory tissue, granulation tissue, and the calcium right there. You see the calcium right there, the gold stuff? I'm taking all that out, and that way it'll allow the disc to heal. All right, what other questions do we have?
Next question comes from Beth on YouTube.
Sure.
They asked, so if I understand that bone on bone doesn't cause any pain.
Yeah. Beth, you are correct. Bone on bone does not cause pain. 100% correct. 100% correct. I know, it's crazy, isn't it? I started to question the bone on bone causes pain a long time ago, early in my career. I'll tell you why. I had people that came in to my office and they had literally bone on bone. They were 70, 80 years old, bone on bone. And they had no pain at all. And I thought, how is this possible? And it wasn't just once in a while. You see these people, it's every single day. They have no pain in their back at all. So I started to say, how could it be that somebody has bone on bone and yet no pain? I mean, I was taught bone on bone causes pain, right? So for years I was perplexed by this anomaly, but it wasn't really an anomaly. It's standard, it's routine, it's what you see every day. I saw patients every single day, 10 of them a day in my clinic with bone on bone but no pain, no symptoms whatsoever. And yet I was taught to tell patients, hey, you got bone on bone, you need a fusion. Again, misinformation, but coming from me. I'm not ashamed of it that I was misinforming people at the time. This is, before I understood that bone-on-bone didn't cause pain, and I was just doing what I was taught to do and what everybody else is taught. But that's the problem, is there's so much misinformation out there being perpetrated or promoted, promulgated by doctors, therapists. They just don't know the truth. The truth is, we don't care if you have bone-on-bone. Okay? It's not causing any symptoms at all. You can live a normal life with 0 symptoms, 0 limitation with bone-on-bone in your spine. Okay? Anybody that says other is full of shit. 100%. It's not even maybe. I'm more sure of that than I am sure of the fact that I'm standing here doing surgery today. Okay? So, there's a lot of mistruths out there. And our new website that's coming out hopefully soon is going to hopefully clear up some of these fallacies. We call them fallacies. But there's a lot of them. Millions and millions of people are living with pain, not really knowing why they have pain, not being given answers, or given mistruths. The biggest mistruth of all is fibromyalgia. I will stand here today and tell you there is really no such thing as fibromyalgia. None. We will fix everybody with fibromyalgia. You bring them to me, I will fix them. We'll get rid of their pain. Now, fibromyalgia, by definition, is uncurable pain. It cannot be cured. You know how many people I've seen and cured their pain when they had fibromyalgia as a diagnosis, coming to me with fibromyalgia as a diagnosis from another doctor? I can't even count how many, thousands. Because the doctor didn't know why they had pain, so they gave them a diagnosis of fibromyalgia. We just figured out why they had pain and we cured it. It was coming from their facet or their disc or their SI joint, piriformis, coccyx, whatever. You name it, we figured it out, we fixed it, got rid of it. There goes the fibromyalgia out the window. So in all these years, 20 years of practice that I've been doing back and neck pain every single day, I've seen 0 cases of fibromyalgia, 0. Now, I've seen many people come to me with a diagnosis of fibromyalgia from other doctors that couldn't figure out what was wrong. And we fixed them, therefore they don't have fibromyalgia, because fibromyalgia is pain that comes from soft tissues in your back or neck, like your fat, your muscle, your fascia, that you cannot cure. Well, we've cured it every single time. So you tell me, is that really fibromyalgia? I mean, I'm just saying. If you understand what fibromyalgia is, it's uncurable. So how could we cure the pain if we're treating the facet or the disc and the pain's gone? Did they really have fibromyalgia? The answer is no, they didn't. Okay? Any other questions? Great interactive questions today.
No current questions.
Appreciate all your involvement. I'm sorry if I'm upsetting a few people, but I tend to have that effect. Not by choice, but the truth sometimes is difficult for people to accept, especially when you've been told something else for years, you know, and you believe it. And that's unfortunately just the way it is. If you're having trouble with the truth, do me a favor. Watch the series. It's called The Matrix. All right? And then when you're done, come back and watch some more of my surgeries. Then we'll be in a better place to understand what's really going on in the world of spine. The Matrix is really it. You patients with back and neck pain, you guys are the humans hooked up as batteries, feeding the machine. The machine is the spino-industrial complex. It's basically the companies that make the metal implants, billionaire company, billion-dollar companies like Medtronic, Johnson & Johnson, DePuy, Alphatec, Nuvasive. It used to be Synthes. These companies that make orthopedic implants, they know we can cure pain without their implants, but they do not want us curing pain without the implants. Therefore, I am public enemy or corporation enemy number 1, because I'm like the guy in the world broadcasting these videos showing that we're curing pain without their implants. They probably have a sniper somewhere with a crosshair on my head, right? Outside there somewhere. The only reason why they haven't killed me yet is because they're like, Titusville, Florida, where's that? Huh. Hell, is that in another country? Where is this Dr. Duke? Hiding out in the boondocks. They send the assassins for me, but they can't find me. Anyway, you got to have some self-humor these days. Otherwise, you just go crazy. You cry yourself to sleep. Fact is, they don't like me, but they kind of leave me alone because I'm quietly doing my own thing in the corner of the world that doesn't really affect their business yet. But I've got plans for them. I've got plans for them. The more the public becomes aware of the truth, the more the public is going to go away from implants. It's 2023. My prediction is that once we get the word out about this surgery, like really get it out to the world, their business is going to go to zero someday. I mean, almost zero. They're still going to do the tumors and the complex motor vehicle accident, spine fractures, and maybe the infections with instability, but they're not going to be doing degenerative spine conditions like they are now. 95% of spine surgery is done for degenerative spine conditions like disc, stenosis, radiculopathy, neurogenic claudication, Cotta-Equina syndrome. I mean, a typical degenerative disc disease kind of stuff. That's 95% of spine surgery today. And that's the type of condition that this surgery works for. And we don't put an implant. We're not putting screws, rods, cages, plates, BMP, grafting. And those companies are going to literally lose billions of dollars. If surgeons suddenly did this surgery, if the patients demanded it and said, I don't want metal anymore, I don't want metal. Nope, do the endoscopic surgery that Dr. Duke Majan does. If they did that, those companies would go out of business overnight, but so would the doctors. The doctors are not prepared for that. They don't have a way to deal with the volume of patients that will want this surgery when they know about it. Okay, because number one, they don't have the training to do the surgery, so they're going to be SOL, shit out of luck. And number two, these doctors don't have the equipment. It costs, literally, I spent $10 million plus on this facility. I had to pay out of my own pocket. There were no grants. There was no Bill and Melinda Gates Foundation donation. There was no Elon Musk donation. I didn't get money from anybody. I had to pony up myself. I had to borrow. I had to put my credit online. I had to borrow money and build this place myself because nobody was going to help me do it. The hospitals weren't going to do it. Nobody wants to do it, right? You're hurting the hospitals' pockets too when you do these surgeries. Hospitals make a lot of money on very invasive surgeries like spine surgery, robotic surgery, whatever. They're making gazillions of dollars a year on those expensive surgeries being done, but they're bad for patients. They're horrible for the patients. They're good for the hospitals, good for the surgeons, good for the implant companies, bad for the patients. You understand? So in the end, I know what's going to happen. You don't need a crystal ball on this one, folks. You know the patients are going to learn about this surgery and they are going to demand it. There's nobody with a brain that will want to have anything but this surgery, the Duke laser disc repair, done if they understood how good of a surgery it really is, how safe it is. There's no complications, no infections, no nerve damages, no instability, no additional surgery, It is literally one and done, usually, for our patients. As long as we figure out where all their pain's coming from, we can fix it right away. I need 1 minute on this disc, and then we're going to move to our final disc. All right, any questions?
No current questions, but we do have a comment from Canes25 on YouTube.
Oh, my favorite viewer of the month.
And they said that they have an oldie to watch this weekend, movie of the week, Apocalypse Now.
Oh, nice. Yeah, I love Apocalypse Now.
Oh, and he just asked a question. What is your opinion of Elon's Neuralink and Neuralace?
Yeah. All right. So what's my opinion on Elon Musk's Neuralink? You're a very smart person for asking me because I'm a neurosurgeon. And what a lot of people don't know about me is that before I was going to become a spine surgeon, I was exactly what Elon Musk Neuralink is. It's called functional neurosurgery. That's what I was. I was a functional neurosurgeon, and I was going to be a functional neurosurgeon putting in implants in people's brains, computer brain interface type stuff. Exactly what the Neuralink is. So you're asking me what I think about it. So here's my answer. And you're not going to be happy about it. I don't know enough about the Neuralink to have an opinion. That's it. I don't give opinions about things I don't know about. So there's a lot of, top secret information. By the way, these are bone spurs right here. You see the laser hitting the bone spurs, just cleaning them up? There's a lot of top secret information about the Neuralink, right? And I'm not privy to it. I don't have access to it. So whenever I have not enough information to really have a good opinion, I don't have an opinion. My wife asks me stuff all the time. It's like, what do you think about abortion? I'm like, I don't have an opinion. I really don't. I don't know enough. I mean, I'm not somebody who would carry a baby to term, under certain circumstances, so I'm not going to have an opinion. I just don't have an opinion on a lot of the things that you guys all have opinions on, because I know that I don't have enough information to really have a solid opinion. But I certainly have an opinion on spine surgery, and I certainly have an opinion on back pain, because I'm an expert on it. I mean, I cure it all the time. This is what I do. I know what everybody does. I know how they do it. I know that it doesn't work. Everybody else's techniques. I know it's dangerous, all these other surgeries. But I know what the best treatment in the world is, and that's what we're doing right here. So I have an opinion about spine stuff, but I don't have an opinion about lots of other things. So I'm sorry. I just don't have enough information. But I will tell you this, since you asked. I did research as a medical student in a neurosurgery lab. I did a lot of neurosurgery research because I'm a neurosurgeon. But one of my projects specifically was to study the seizure activity in rabbits' brains using what are called voltage sensitive dyes. And my job was to basically create a hole in a rabbit skull, remove the dura, and to expose what we call the cortex, the cerebral cortex, which is the brain, what you guys know as the brain, and to put these dyes in there and induce seizures, and then study the propagation of these action potentials of neurons involved in epileptogenesis. So I studied cortical function with that rabbit model, and one of the biggest problems we had was the formation of this scar tissue basically on the brain surface, and it would really opacify the surface. And when I started doing my functional work at Shands Hospital in Gainesville with Dr. Roper, I was studying epilepsy again in rats, and also working on humans for 2 years in my fellowship, which was NIH funded as a principal investigator. Long story short, we had the same problem in humans where scar tissue would form between the electrodes and the brain. Therefore, the signal between the brain neurons and the electrodes was impaired dramatically. So my concerns with the Neuralink are, how are they going to prevent that scarring that occurs between the brain and the interface, the electrode basically? And it's interesting because back then we had metal electrodes, but I know that you can use other materials as electrodes. And perhaps there will be some type of a material that will not induce the scarring formation that occurs between the electrode and the brain parenchyma. So that has to be solved. And I think that's something nobody talks about, because I don't think they've solved it. And I think, I hate to say this, but this goes back to what I say all the time in healthcare. There's all these companies like Neuralink, they make a big stink, the Neuralink stink, and they basically try to generate public interest, and then they sell stock. Come on, I need a shot. at a very high amount to quote-unquote investors, Sean. And of course, it's called pump and dump, for those of you who don't know what I'm talking about. Now, I'm not suggesting Neuralink is garbage and it's pump and dump, but I see pump and dump happening all over healthcare. And I don't trust most of these quote-unquote inventions or applications of technology that they're pumping and trying to get investors to invest in, okay? If you want to know the greatest investment in healthcare right now, you're watching it, this surgery and the Duke plasma rhizotomy. This is the biggest and best investment in healthcare, because the number one reason people go to the doctor is back pain. It's the most common problem people have, and we've discovered the cure to back pain. So this is the greatest discovery in healthcare in a long time, you know? That's in my opinion, for whatever it's worth. Think about the implications of curing back pain. 100 million people in North and South America with chronic back pain. And if you talk about worldwide, you're talking about probably 500 million people worldwide with chronic back and neck pain that I could cure. If I could put them all on this operating table, I have to see them first in clinic, of course, and get an MRI and maybe a nerve test, but I could literally cure all of them. I need a bigger clinic. Yeah, 500 million people, that's a whole more than a lifetime. The problem is that I can't do it all myself because I'm just one person. And as much as I love doing these surgeries, I need help. But, you know, number one, I don't trust other doctors to train them. And number two, there's not enough demand for me to keep me busy full time yet because people don't know about it. So Neuralink's going to be interesting. I don't, you know, you have to ask yourself, what is the ultimate goal with Neuralink? Like, what are they trying to achieve, right? And the problem is there's so little information on what they're going to achieve that it leaves a lot up to the imagination. And I think that's dangerous when people are looking at investing one way or the other into a technology that they don't really understand how it's going to improve their quality of life or change their life. You really need to understand the application of this technology before you can understand its value. And then, of course, there's a risk to the technology, which I discussed, and that's just only one risk. Of course, there's risk of infection in the brain. I mean, my God, if you get a brain infection from putting the Neuralink in, which is going to happen, by the way, it's going to scar your brain, and then you're going to get seizures. You're going to have brain damage. I mean, who the hell wants to go have a chip put in their brain and get brain damage? Right now, if I had to guess, I'd say the chance of serious complications with Neuralink being implanted in somebody's brain through an open brain surgery is at least 5 to 10%. Now, there's really good surgeons like me, right? There are mavericks out there in brain surgery where we have very, very low complication rate. But, you know, can you eliminate risk completely for brain surgery? No, you cannot. And the problem is that the adverse events like infection of the brain, meningitis, encephalitis, cerebritis, hydrocephalus is another one. Oh my God, if you get hydrocephalus from that thing, which is extra water on your brain, that's what we say, you're going to have a shunt put in, or you're going to have a third ventriculostomy. You know, you're talking about, you're going to have a shunt most likely put in. I mean, who wants a shunt? That's like the worst thing in the world. Shunts malfunction in the middle of the night and you die from herniation. So my initial impression, without knowing any more, and I don't want to be the spokesperson for technology I don't know enough about, is I would be very concerned because there's some serious challenges they have to overcome. And if you're thinking about investing, I'd be just cautious, you know. It's kind of like, for me, I don't invest in Bitcoin because I don't trust it. And I just feel like it's unregulated and it can go up or down and you could lose a lot of money. And I don't invest in things that I don't fully understand. So that's just me personally.
We have another question.
Sure.
This comes from Darren on YouTube.
Darren, hi.
They asked, what are your thoughts about 3D imaging for this surgery?
What are my thoughts about 3D imaging for this surgery? You know, Darren, it's a great question. Honestly, I don't know that it would add much, you know, maybe to the user experience like you guys watching, perhaps, but you can't really get any better than no complications, 1 hour recovery, and 100% relief of pain from the disc. I mean, literally 100% pain relief from the disc that we're operating on, plus no complications, plus 1 hour recovery back to work the next day. I mean, adding 3D imaging, what's it going to do? Well, how is it going to improve my outcomes, right? So if you could show me it'll improve my outcomes, then I'll do it. I've looked at it. I just don't see how 3D imaging is going to improve my outcomes. I just don't. Does that make sense? In other words, I don't do things just because they sound cool and sexy. I personally would never bring in a new variable on a patient in their care unless I was 100% sure it's going to make them better. And or if it's a change in my technique or practice, I would want to know that it's going to make things better. Like, we do change things, right? For example, one of the changes we just made recently at Duke Spine, we started using CPAP machines, which actually, it was interesting because when you're doing a prone propofol IV sedation MAC patient like we are for the lumbars and thoracics, the patient's facing down and you've got oxygen on a face mask, but you could still have trouble with their airway, and having forced ventilation through a CPAP machine, the patients who had sleep apnea and were getting the surgery done, we noticed they were doing better with that CPAP machine with forced ventilation. And you know, Dr. Berndes and I talked about it, and we made a change. We bought some CPAP machines, and we're using them on regular people now that don't even have sleep apnea because it's safer for them now. So we do make changes. We do assess technology. We do look at, hey, you know, how could this technology make it better, make it safer? And we will, you know, spare no expense. I assure you, at Duke Spine Institute, we will spare no expense to improve safety, as long as it really improves safety. I don't believe in bullshit improvement safety, right? Like, huh? Yeah. Yeah, Dr. Berndes says he can attest to that. We will spare no expense for safety. We have literally every piece of equipment that you can buy, no matter how much it costs. Doesn't matter. If it's going to make this experience safer for the patient, we will invest in it and we'll have it available. But see, hospitals don't do that, because hospitals, it has to go to their committee. The committee has to analyze it for a year or two, and then, you know, they rarely will buy equipment. Oh, there's a herniation. You see that? That little thing that just came out? Hospitals will rarely invest in new equipment. Like, I remember when I was doing surgeries at the hospitals locally, and it's true for any hospital, they don't have the budgets. And by the way, truly, hospitals' margins are usually 1% to 4%. So if they made $200 million in a year, their profit margin is going to be somewhere around 1% to 4% of 200 million. All right, I know this for a fact for many reasons, but suffice it to say, I was the chief of staff at the hospital here, one of the hospitals, for several years. Chief of staff means the highest doctor position in the hospital. I was overseeing all the other doctors. So as chief of staff, I met with the board all the time. I learned about the finances, blah, blah, blah. And it's just in practice, hospitals don't want to spend money on equipment or staff, but they will. They waste money on staff, to be honest with you, and they won't buy the equipment that's needed to make the patient experience safer. So one of the biggest wastes, in my opinion, the biggest waste right now is these electronic medical record systems. When I started practicing medicine many years ago as a resident, it was all paper charts. And paper charts work fine, honestly. Now, there are some nice advantages to EMRs, but the moment the government mandated EMRs and everybody has to buy it, and they were raising the prices, like literally for software, right? If you go online and you want to buy a video game, you might pay $50 for a video game, right? $50, and you get that software. Well, these companies that made these databases, which literally are less complicated than a video game, okay? And you're not paying $50, you're paying $1 million or $500 million. Heck, the VA system literally bought Cerner, and they're spending over $5 billion on Cerner. Billion for software. Okay? There's something wrong with that. That is disgusting. We're wasting our precious financial resources on corporations that are not helping with making the patient care better. They're not improving safety. They're not improving the quality of the procedures. They're literally just sucking money out of healthcare and lining the pockets of dirty politicians and dirty corporations that don't give a shit about the American people. Okay? They just want to profit off you. So that pisses me off. And believe me, we've got our own stuff we've got to deal with at the surgery center at Duke's Spine. We've got all kinds of things we have to pay for that we shouldn't have to pay for because the government requires it, and they don't improve safety. They don't improve quality. So I've got massive expenses on things that I got to pay for because that's required. And we're not going to break the law, of course. But then again, I got things that are not required, but they are definitely helping patient safety. And we're going to buy those too. So there's a lot of money being spent on equipment, supplies, etc., processes, things that will improve patient outcomes, and then of course a lot spent on things that won't improve patient outcomes that are required by lawmakers because they're being basically bribed and not bribed, but paid. They're being paid money as a kickback by corporations that produce those things that they're requiring us to have. Okay? That's healthcare. That's America today. It's corrupt. And in the end, the people have to pay the price for the corruption in their government. All right, other questions?
This next one comes from Canes25, once more on YouTube. And they said, my friend's wife has lumbar scoliosis and previous surgery with sciatic pain. I gave them your info, told them you're the guy.
Thank you. I appreciate that. Good news is, every one of these patients we're doing the laser that's working on them, they all have scoliosis. So we're not fixing the scoliosis. We're actually fixing the pain, the source of pain, without fixing the scoliosis. So that's another example, folks. For those of you out there wondering, scoliosis doesn't need to be fixed. Spondylolisthesis doesn't need to be fixed. Degenerative disc disease doesn't need to be fixed. Bone on bone doesn't need to be fixed. All those conditions do not cause symptoms. Now, scoliosis, if it gets really, 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 really bad, yeah, you're going to have your whole body twisted like a pretzel. And yes, it looks bad, and at some point it actually starts to cause some really bad symptoms, you know, once you get like 40-degree curve, you know, once you get a really big curve. But most people with scoliosis don't have a 40-degree curve. You know, they have a much smaller curve, 18 degrees, 20 degrees, 25 degrees, and all those people can have the Duke laser disc repair to get rid of their symptoms, like sciatica or back pain. They don't need a scoliosis surgery. 5 minutes? We're going to be done in 5 minutes. I'm almost done. This disc, by the way, compare it to the first one. There's a lot more disc material still there. There's a lot bigger tear. There's a lot more nuclear material. You can see the end plate over there on the left. That's the surface of the bone. And I'm going to try to see if I can grab out any hunks of herniation with a grabber in a second. Any more questions?
Yes. This next one comes from Donna on Facebook.
Hi, Donna, on Facebook. Welcome to our live stream.
They said, I have been fused from L3 down in the lower back and also fused in my neck. Having trouble in the hips and legs and also in my neck and shoulders. Can you please help me?
Yes, we can help you, Donna, 100%. The pain you're having shouldn't be there, and we can figure out where it's coming from, and we can eliminate it for you. If I had to guess, if you've been fused from L3 to your sacrum, your hip pain is coming from your sacroiliac joints, your SI joints. Look it up. Sacroiliac joint pain. I'll bet you that's what the problem is. Now, of course, I don't know that for sure until I've examined you and looked at your imaging. You know, of course, I'm also assuming you don't have an infection or anything weird or serious like that, right? So assuming you don't have anything weird or serious like an infection, then I would expect your pain to be coming from your sacroiliac joints, SI joints. Look it up. We fix that all the time. We use a Duke plasma rhizotomy now to deal with it. Basically, we go in with a special probe that we pioneered and developed here, and we go in and with this technique and we zap the pain nerves causing all that pain. We do it without fusing your SI joint. A lot of people are told they need an SI joint fusion. They don't. Your surgeon might tell you to go get an SI joint injection and then you need an SI joint fusion. Don't do it. You know, they're just going to keep fusing you as long as you keep coming back. These doctors, I tell you, all they care about is their money. That's all they really care about. And I hate to see people are victim to their highly invasive treatments that don't really work and just cause the need for more treatment like you have, Donna. I'm sorry to hear that. As far as your neck goes, I'll bet you have facet joint pain in your neck, but I can figure that out very quickly. So Donna, use the link that Henry is going to type in right now. It's called mri.dukespine.com, and basically it's a way for you to fill out a form with your information and then send us your MRI scan of your neck and back. You're going to need a new one after your surgery, obviously, and send that to me and I'll look at it and we'll figure out with an exam, a physical exam over the internet. We do it by Zoom. I can figure out exactly where your pain's coming from, and then we can give you a recommendation for treatment. Okay? We do that for free. We've been doing that for years. We do it to help people like you get out of pain. Not everybody comes here and takes advantage of our treatments. There's a herniation right there. You guys see it? It's pretty obvious right there. See if I can grab it, nab it. Uh-huh. Just about done. About 2 more minutes, I think, doctor, and we'll be done. Yeah. Let me just, there's still some stuff here. This disc is a newer herniation. It's obvious to me. This thing happened more recent. That L3-S1 is an older herniation. This is a newer herniation. Any questions from our audience?
Yes. This next question comes from Darren, once more on YouTube.
Yeah, Darren.
They asked, would you use a mechanical laser for this procedure?
I'm sorry, would you use a what?
A mechanical laser for this procedure.
Mechanical laser. I'm not sure what a mechanical laser is. I mean, we're using a laser. The laser we use is a holmium YAG laser. It's a medical laser. I'm not sure what a mechanical laser is. But you see that glass thing right there that's zapping away the herniation? That is the glass fiber that transmits the laser energy from the machine over to the patient's disc. So you really can't see the laser itself, but the machine is big. It's a big machine. It's a luminous power suite, right?
Yes.
100 watt.
100 watt, yeah.
And that's the best you can buy. So I'm not sure what mechanical laser you're talking about, but this is the best laser that money can buy today for medical, and that's what we use. You know, one thing you'll learn about me is that I don't compromise with quality. I'm not going to buy something because it's cheaper and I'll save money if it's going to be worse for the patient. I will never cut corners to save a buck, so the patient will end up suffering because of that, not having as good a result. That's just not in my blood, not in my DNA. Boy, this is still herniation here. You see all that? It's just lateral. I had to look laterally. So if you're doing this kind of surgery in the future, make sure you look laterally as well. I didn't know about looking laterally for a few years when I started doing these. And I had a patient come back and they had a lateral herniation that I missed. I had to go back in and get it. And that taught me a lesson. Make sure you look laterally. Next question.
Next question comes from Teresa on Facebook.
Uh-huh.
They ask, does cervical bone spurs cause pain in the arms and hands?
Do cervical bone spurs cause pain in the arms and hands? No. Nope, they don't. It's the herniation that does. And we can fix it with the laser surgery. I just rarely see bone spurs causing symptoms. They're going to be there, but they're not causing anything. It's kind of like if you go diving with a shark. Have you ever gone diving with a shark? I mean, sure, great white shark's going to eat you, but if you go in the Caribbean diving with a shark, they leave you alone. Bone spurs don't bother you. They leave you alone. All right, they're there, you know, they shouldn't be there, maybe you could say that. Sharks have a right to be there, of course. That's their home. But the truth is that the bone spurs don't bother you. Sharks don't bother you either when you're diving. They leave you alone. Of course, you're going to see somebody show me a shark video, right, attacking somebody. I guarantee you the person they're attacking is a what do you call it? Spear fisherman. You guys know what I'm talking about? When you spearfish out there with a spear, you're spearfishing. You're actually shooting fish with a metal rod, basically an arrow attached to a line, and the fish are bleeding. And what do you think brings those sharks? They're there for the fish. They're not there for the diver. They don't care about the diver. They want the fish. So all these people, they post these videos on YouTube of their shark attack while they're spearfishing. Honestly, I'm rooting for the shark. You got to be stupid to go out spearfishing with sharks around by yourself. The shark's just doing the rest of us a favor by, you know, editing the gene pool. Right, Luis? Anybody that goes out in the ocean on a reef and invites the sharks in by putting blood in the water, I'm sorry, but they get what's coming. All right, 10 seconds. We're just about done here. So this is where the herniation was. I just cleaned that whole thing out with the laser. You guys see that? It's all gone. Now, some people ask me, did you get all the herniation? How do you know you got all the herniation? We don't. We don't get all the herniation. We want to get about 50%. 50% is the magic number. If I can get 50%, that's going to fix the patient's problem. Just grab her. The best I could ever get is 90. Nobody gets 100. Nobody. No doctor in the world gets 100%. All right? That's just a fact. All right, let's look at the nerve. Nerve's up there and the fat looks good. It all looks good. We're good.
Lights on, please. Thank you.
We're done. All right, if you have more questions, I want you to type them up. I'm going to come answer them for you face to face so you can see my pretty face. I actually shaved today. You might recognize me. Type your questions up for me and I'll be right there, okay? Henry, in the meantime, why don't you introduce the audience to one of our past patients that has had this surgery. And actually, before you do that, let me show you the incision real quick, okay? Can I do that, Henry?
Copy that.
All right, let's show you how we did this. 3 discs fixed, 1 incision. There's only 2 ways to get rid of this man's back pain. 2. One is this surgery you just watched. The other is a fusion. Now, I've done over 1,000 fusions on people's backs. Oh, by the way, look at all the pieces of herniation here. I want to show you a couple of things. First of all, I'm going to take this. You guys see the whole surgery here was done through a tube? Oh well. Can you guys see that tube?
Yes, we do.
This tube, 7 millimeter wide, 1/4 inch. Whole surgery is done through that thing. Now, if I didn't do the laser surgery on this patient, we would have done an incision that long right there. You guys see that? Easy, that long. At least 9 inches. That's the typical spinal fusion incision, okay? But instead, our incision is just 7 millimeters. It's tiny. You guys see it?
Yes, we do.
All right, now I want to show you something else. Check this out before you go to that patient. Look at all the pieces of herniation on this blue thing. You guys see it? There's more over here. All these are little pieces of herniation. They all floated out. So the laser breaks them up, the herniations into little pieces, and they float out. And that's where they get trapped on the drapes. Okay? Type your questions up for me. I'll be there shortly to answer them. Our next surgery is going to be a lumbar DLDR, 2 levels. So this patient came from where? Missouri. I'm sorry, I never said it earlier. Our patient is from Missouri. Missouri. Huh? Missouri. I know we have a patient from Michigan later today. We've got a patient from North Carolina. And the next patient is from California. So today we've got 4 cases, 4 surgeries at Duke Spine here in Florida. This patient's Missouri. The next patient's California. The next patient after him will be North Carolina. And the last patient is from, what did I say, Michigan. Okay? So our Indiana. Was it Indiana? I thought it was Michigan. All right. The insurance says Michigan, but that's fine. Indiana. So all over the country, thank you for watching. Go ahead and take them off to a break, and I'll be with you shortly. And good morning, I'm Dr. Duke Majan. I'm here with one of my lovely patients from Canada who's visited us because her back has been hurting for 7 years. She's had a herniated disc that she's been kind of monitoring at L3-S1. And finally, it really started bothering her a lot over the last 7 months to a year, causing pain down into her right leg. So she decided to do something about it, and she went to see her doctor in Canada, who then said, yeah, I'll have you see the specialist in 3.5 years. Well, that wasn't going to work for you, right?
No.
Yeah, because you don't want to live in pain for 3.5 more years. And even then, you don't know what you're going to be offered. But she found the Duke Spine Institute and learned about the Duke laser disc repair endoscopic surgery. And you had it done yesterday.
Yes, yeah.
How are you doing?
I'm feeling great today. I have no pain in my back. I have some tight muscles from me having to walk very oddly for quite a while due to the sciatic pain. I must say, this is the happiest I've been in a very long time to be able to stand up straight and go for a walk. Because I'm an active person as is. I ride horses for a living, so having to be locked up in my room for the past while has not been good. So this has felt amazing, amazing.
So you're happy with the results?
Very. I feel very hopeful also to be able to do what I want to for the rest of my life.
Yeah, after we let the disc heal, right?
Yes, full year of nothing, and then we can.
Yeah, I wouldn't say nothing, but you know, horseback riding, it's one of those things where I love horses and I love riding horses. I'm not very good at it, but I'm one of those people you see bouncing up and down, up in the saddle. So I know that it can be rough on your back, and I just want to make sure you give your back a full year to heal. So you can see in your surgery right here, we actually tested your L3-S1 disc with a discogram, which is a test done to verify that that disc is indeed causing your back pain. And when we tested it, you said, and we asked you how bad it was. You said 10 out of 10 pain. And I said, is that your typical pain you get every day? And you said, yes, it is. So we verified the source of your pain was the L3-S1, and you can see the laser was used to clean the tear endoscopically. Your incision was only 1/4 inch, and there's no need for fusion or metal or artificial discs. This surgery replaces fusion and artificial discs. What are you going to do now that you're feeling better?
Well, it's, again, don't worry, I will take it easy, I promise. But no, I'm going to be, after this, this year, I hope to be the strongest I've ever been, and I have very high hopes and whatnot. My dream is to make actually the Canadian Olympic team for my sport, And that's end goal, and I feel like it's a possibility now.
Absolutely.
To be able to do it.
You can.
Yeah.
We're rooting for you.
Mm-hmm.
And I know you have an incredibly supportive husband who's been by your side the whole time. He's a delightful young man, and I've had time to talk to him as well. So you're lucky you have support from your family to help you get through this.
Yeah.
Anything you want to say to your fans out there?
Oh, geez, I don't even know where to start other than just this place really can offer you really what either you deserve or what you need going forward to be able to live a happy and good life. And it's amazing to me that literally it was yesterday I woke up from it and I went for a short walk like immediately, and I felt amazing. So it's very hopeful, and if you are suffering from any of it, don't wait, especially for the Canadian system. Come and do this. It's worth it. It's really worth it.
Awesome. And I'm going to be, and my whole team is going to be watching the equestrian sports and the Olympics, looking to see for you to be there.
Yes.
All right.
Awesome.
And
Amazing.
of course, supporting you.
Thank you. Yeah.
All right. Congratulations.
Thank you.
All right. Take care. This is Dr. Aru Duke-Majan, CEO and founder of the Duke Spine Institute. I'm here with one of my patients, and you've traveled from where to the Duke Spine?
Idaho.
Idaho, with your lovely husband, and we've had a few conversations. She came here to have her back fixed. How long have you had back pain for?
For over 7 years.
Okay. And what kind of work did you do before you retired, if you don't mind me asking?
It was desk work.
All right. And so you had back pain for 7 years. Did you have an injury to your back, or did it just kind of gradually come on?
It just gradually came on. I actually noticed it first in 2015 when I was gardening and I couldn't be up there for 8 hours. I was into it for about 4 hours and I had to take a break. And as time progressed, my breaks got longer and longer, and the amount of work I did in the garden was less and less.
Understood. And you're retired now. So what's it like having back pain limit your ability to do stuff when you're retired?
For me, it's very frustrating. I can't do that what I want to do. So we kept seeking solutions and nothing was working. They did work for a short while, but that short while decreased over time. It was shorter and shorter. My husband does research very, very well. Through his research, he found you. We read that you can fix my back, and you did fix my back.
That's right.
And I thank you.
You're welcome. So when did you have the Duke laser disc repair done and the Duke plasma rhizotomy?
I had those done yesterday in the afternoon. I am sitting straighter than I have. I'm standing straighter. I'm walking normal. It's like, wow, new me.
Look at that smile right there. I hadn't seen that until just now. So
well, it wasn't there yesterday.
Yeah, it wasn't there before surgery. And how long have you been not smiling because you've been in pain? I mean, really bad pain. How long has the really bad pain been there?
Well, the really bad pain has probably been over the last 5 years. It's something that was really tough to maintain a positive attitude and try to keep a smile on my face and keep Jeff's hopes up. I tend to be a positive person, but there were times when it does drag you down.
Of course, yeah. It's hard living with chronic pain, and especially with loved ones, they have a hard time, relating. Of course, they want to be supportive, and your husband is a very supportive man, obviously. And he's a pleasure to meet. I know he's an author as well. Yes. And so what are you going to do now that you've had the surgery? And you could see actually the Duke laser disc repair procedure she had done yesterday. You can see right here, we went into the discs that were damaged. You had 2 annular tears. We tested your discs during the surgery, and indeed they were causing your pain. So we verified that with our discogram. And then I went ahead and used the laser to clean up the tears that were causing your pain and get rid of that source of pain for you. And here you are, you're doing fantastic. How much of your back pain from before surgery do you still have?
Oh, virtually nothing.
It's gone.
It's gone.
Cured.
My lower back, I have not been without pain in my lower back until your surgery. It's constant, it's always there. I've never been without it. I'm without it now.
So are you going to go back to gardening?
You bet I am.
All right, very good. And what other things would you like to do now that you have a new back that doesn't hurt you anymore?
You know, the biggest thing I want to do? I want to go fly a kite.
Good for you. Let's go fly a kite then.
That's right.
Well, congratulations on having faith
Oh,
and being
thank
brave
you.
and getting it done.
No, not a problem.
Is there anything else you want to say to your fans out there?
I highly recommend Dr. Duke's Spine Institute, Dr. Duke personally, to help you fix your back.
Thank you. Appreciate that. All right. Safe travels.
Phew, that wasn't too bad, was it?
It was wonderful. And I'm Dr. R. Duke Majan here at the Duke Spine Institute. I'm smiling because I'm sitting with my first surgical patient of 2023. I don't know if you realize that, but you were the first one of this year, of the new year. Now, you had the Duke laser disc repair done on your lower back because you had 3 bad discs, and we did that yesterday.
Yesterday, yes.
And here you are, one day later. How do you feel?
And I feel good. I feel good, and the pain that I've been suffering for months is gone. I mean, I'm a little bit sore, but that's from the surgery itself.
Yeah.
But otherwise, I feel good. Feel good.
Now, you've had back pain too, on and off for 30 years. We were talking about that. Tell us about those episodes of back pain. What do they do to you?
The first one that I recall was pulling out a sofa bed thing. And I got so far with it, you know, we had company and I was opening up the bed, and all of a sudden I just could not move. I couldn't move. My husband had to practically carry me. So I was out of work for a week or so, and then at the chiropractor, and then gradually it got better, and I thought, well, that's fine. And I moved on, and then, you know, had a couple other times like that. One time I was drying my hair, getting ready for work, with the blow dryer going like this with my hair, and all of a sudden, it's like I couldn't move. I couldn't move my arm down. I couldn't, I mean, it was that quick.
Yeah.
And just, I was out again for another week, laying in the bed and doing all that stuff. And then I thought I was fine, but I always, not always, but for many years now, probably at least those 30, I had lower back pain, where in the morning I couldn't bend over to brush my teeth. You know, that would really hurt.
Yes.
So I had that.
Do you have that pain now?
No, I don't think so.
It's gone.
The pain this morning, I was the first time in a long time I've gotten up first thing in the morning and was able to walk and not have that awful pain, because first thing in the mornings was the toughest.
I'm so happy for you. So how is this surgery going to help you in your life?
Well, hopefully once I can at least walk again. I was not able to barely walk with a walker. I was very active in my church and my community.
So you want to get active again?
And being in such pain now since July, and this is the new year, I'm anxious to get back to, you know, my life.
Yes, of course. Well, you had 3 herniated discs in your lower back, and you can see in the footage where we went into each of those 3 discs, and I used a laser to clean the tear, where you had a tear in the back of each of those discs called an annular tear, and the jelly from the center was stuck in the tear, holding it open, allowing more herniations to come out. So I got rid of the jelly that was in there using the laser, cleaned out the tear, and now your body will be able to heal that for the first time in 30 years. So I don't expect you to ever have that pain ever again.
Thank you.
You're welcome.
I am so thankful.
Well, you had faith and you found us.
Yes, I did.
You did what's right for your body, and I'm excited for you. So
I believe I did. I just kind of was led to you, and it just all went bing, bang, boom, and I didn't ask a whole lot of other people what they thought. I just did what I thought I needed to do.
Good.
For me.
Is there anything you want to say to your fans out there?
I would recommend that if you do something to your back, that you take care of it early on. You take care of it right away. The longer you wait, the harder it is and the longer it takes.
It takes a toll on your life.
Oh, definitely. It has taken a toll on mine since this summer, for sure, where I have not been able to sometimes not function at all, barely be able to sit in a chair. and be comfortable without squirming because I couldn't find that exact place where I didn't have pain. You know?
I don't see you squirming anymore.
No, I'm not squirming. I know. That's great. Sit here without pain.
Congratulations.
Thanks to you.
All right, have a blessed day.
Thank you. You do as well.
And I'm Dr. Dumajian. I was just with you in the operating room for this patient where he had 3 of his discs in his lower back that were repaired. Just to give you an idea of what's happening inside the spine is called the spinal column. It's made up of bones. That's the yellow things stacked on top of each other. And between these bones, so that they can stay flexible and be able to twist and be able to bend back and forward, be able to compress a little bit when you're picking things up, you've got these little cushions between them called discs. And these discs, the further down your spine you go, the more weight the spine carries, the bigger the discs are, and the more robust they are. But even though they get bigger and stronger, more robust, they still get injured. The most common injury to a disc is an annular tear, and then after that you can get a herniation where the jelly in the center pushes out. So to avoid fusions, you need to have an option that actually cures the back pain and leg symptoms, and that's what the Duke laser disc repair does. Instead of coming through the spine, translaminar, going through the lamina, removing the lamina and the ligaments, and then trying to get around the nerves, we actually come from the side. And this was an approach to the spine called transforaminal. You're going through this hole, it's called the foramen. Trans means you go across the foramen, transforaminal. I did not discover it. It was discovered by Dr. Parviz Kambin, P-A-R-V-I-Z, Kambin, K-A-M-B-I-N. He was an Iranian doctor, an orthopedic surgeon. He practiced in Pennsylvania. And he was it's the wifey. He was a pioneer in spine surgery. He was the first person that said, hey, you know, he was looking at the spine and he was going, why are we limiting ourselves to go and approach the discs through the back when, hey, you know, there's this window that's already there, we could go through that window. And that takes you right to where the disc problem is. Very smart man. He taught my mentors how to do the surgery, endoscopic, transforaminal. This was back in the 90s. And my mentor, Dr. Anthony Young, in the 90s, I was still in college. Dr. Young and the Koreans and German, Dr. Hellinger, they taught me back in 2006, 2007. They taught me how to do the endoscopic, transforaminal, and transdiscal cervical surgeries. And of course I modified the surgeries and made them better, and that's when I brought in the laser and did the annular debridement and published it as the Duke laser disc repair. So the patient you just watched having surgery, we fixed 3 discs with 1 incision, 1/4 inch Band-Aid, and he's going to go home in about 45 minutes. He's waking up right now. In the meantime, we're getting our next patient ready for surgery. I'll take questions.
First one will come from Chris Costa on YouTube.
Hi, Chris.
Asking, is there any danger having a hot laser in the disc or close to the nerves/spinal cord? Is there a risk they might be burned?
Great question. So is there any risk the nerves will be burned by the hot laser? It would be the same risk of burning your nerves with a hot laser with a surgeon who knows how to use the equipment, the same risk as when you're eating dinner that you stick your fork in your eye and pop your eyeball out. So could it happen? Sure, you know, right? The fork's awfully close to the eye, but you would really have to mess up pretty bad to hit your eyeball. So the answer is yes, but not really. I'm not sure how to answer that. Is there any risk? Yes. 1 in a 5 million, 5 billion, somewhere in there. But if you have a surgeon who's an idiot and doesn't know what they're doing, then I think the risk would be higher. So, yeah.
Next one comes from Miran on Facebook.
Miran, welcome back, Miran.
And they said, "Hello, doctor. Good to see your work again on my feed. What
Thank you.
is your experience of having leg discrepancy, longer leg than the other, as possible cause of herniated disc forming over the years?"
Great question. So Mirren says, hey, if a patient's got one leg longer than the other, it's called a leg length discrepancy. Could that cause a herniated disc? Well, it's a great question. I think it could contribute to it. If you've had a leg length discrepancy for many years, that means your pelvis is going to be compensated because you're kind of pulling your spine, trying to straighten things out because one leg is shorter. So to walk equally and evenly and straight, you've got to compensate. Could that cause the annulus to wear out and tear faster? Sure, it could. Do I have much experience with that? I do not. I do see a lot of patients with leg length discrepancy, but typically they present to us with a piriformis syndrome or a trochanteric bursitis or a sacroiliitis or facet pain. So one of those four, they usually don't have a herniated disc as a result of that. Their problem is more trochanteric bursitis, which is hip pain, piriformis, which is a strained muscle in the buttock, we treat it with a shot, sacroiliitis, and facet pain. So, but not really herniated disc. Great question.
Next one comes from Chris again, once more on YouTube. Have you heard of epidural PRP or ozone injections into discs to treat disc herniation?
Yeah, Chris, absolutely. Great question. So have I heard of epidural PRP? Yes, absolutely. We do PRP injections here at Duke Spine. We've been doing it for 15 years now. And then we do stem cells as well, ozone, same thing. Yes, I've heard of it. No, they don't work. I would not waste my time or money doing any of those treatments. They don't work. Understand something. Duke Spine Institute, the treatments we do are vetted treatments. If you know what vetted means, it means we've taken every single treatment available in the world to treat a back problem. We've looked at them and we stacked them and ranked them. And then there's number 1, there's number 2, number 5, 10, 20, 30, number 553. Okay. Number 1, the very best treatment of all is the Duke laser disc repair, what you just watched. That is the top. And by the way, second is literally like the Duke laser disc repair is in outer space. Second is down somewhere right on Earth's surface. And then third would be just a millimeter below that, and so forth. And some of the treatments are really bad, okay? But doctors recommend treatments, unfortunately, not because they're the best treatment for you, but it's because that's what they do. That's the only thing they know how to do. So when you hear about people being recommended for ozone or PRP, you know, these are scammers, basically. I would stay away from them. Do not trust them. All they want is your money. Ozone and PRP are not going to be paid for by insurance. You'll pay out of pocket for it. They will not fix your problem. I can't tell you how many thousands of people come here to Duke Spine having had ozone, having had PRP, having had some other treatment. They don't work. The mild procedure, interspinous device, Regenix, disc seal, barricade device. I mean, the list goes on, right? And of course we could do those surgeries. That'd be like, you know, me brushing my teeth and not hitting my eyeball. It's easy to do. Those surgeries are easy to do. But what's not easy about those surgeries is dealing with the guilt that I would feel for doing a surgery that I know doesn't work on a patient. I just can't live with that guilt. That's not something that I want to live with, and thank God I don't have to. I don't have to sell patients on surgeries that don't work, that I know don't work. I've been able to avoid having to do that. I would rather make no money and have no surgeries in my surgery docket than have a surgery that I'm doing that I don't believe in because I know it's not going to work for the patient. All right? Unfortunately, or fortunately, I can't sleep at night knowing I'm doing treatments that don't work and that are dangerous. So that's my problem, is God gave me a conscience. And I think God gave a lot of other surgeons, he gave them a different kind of conscience. Sorry if I offend you, but it's the God's honest truth. And by the way, in case you haven't noticed, I've evolved a little bit beyond worrying about offending people in my point in my career. All right, I'm not worried about offending you. The truth is, I don't care if I offend you or not. I'm not here to make you feel good. I'm here to give you the facts. That's why we do this broadcast. It's to share the truth. It's not to, we're not touchy-feely people. We're not psychiatrists here. We don't fix you by talking you out of your pain. We fix you by actually getting rid of the pain at its source. So I'm not known as the most sensitive person in that sense. I'm sorry. It's one of the things that God did to me. Maybe he was being cruel and mean to me by making me somewhat of an impatient person. But it's that impatience that drove me to discovering cures to back and neck pain that we offer today to our patients and are curing them. So that same personality that some of you find offensive, that's what drove me to become successful at solving this problem and other problems, by the way, which I don't talk about.
Next question comes from Teresa on Facebook, and they asked, I have degenerative disc disease in L5 and L4. Could this cause foot pain?
So Teresa has degenerative disc disease at L4, L5. Could this cause foot pain? Great question, Teresa. So a degenerated disc by itself will not cause foot pain, ever. But if a degenerated disc causes stenosis, stenosis is narrowing of the holes where the nerves come out, okay? So you can actually have a narrowing of this hole where the nerve comes out and it goes down to your foot. But here's the thing. If you have stenosis causing a pinched nerve, then you would have more than just foot pain. You would have pain shooting down your leg. Hello. Thanks. So you can't just have foot pain from a pinched nerve from stenosis at L4-5. You've really got to have more than that. You would have aching in your leg, cramping in your leg, some kind of other symptom, but not just foot pain. If you're having just foot pain, I would recommend seeing a podiatrist. But you could also see me. We do these virtual consultations, and you're welcome to do the mri.dukespine.com free MRI review. Upload your MRI.com images on our portal, or send your MRI in by CD or zip drive, or give us a portal link for login with login credentials, and then we can actually look at your MRI together. I do not think your foot pain, if it's isolated foot pain, is coming from your back. You probably need to look at foot causes, or something like gout, or something like plantar fasciitis, or a spur on your heel. That's probably a more likely cause of foot pain.
Next question comes from Chris once more on YouTube, and they ask, can bone spurs get bad enough to impinge a nerve, though? At that point, they could be causing symptoms, no?
Yeah, Chris, great question. Can a bone spur get big enough over time? Yes, they do grow, you're right. They do get bigger. Can it be bad enough to impinge on a nerve? So the answer is yes, you're right, they can. However, before the bone spur itself is the cause of the impingement, you're going to have so let me back up. Bone spurs occur at joints. And there's two types of joints in your spine. There's the facet, there's the disc. So when you get bone spurs, they're happening at the disc, or they're happening at the facet. And what I'm trying to tell you is that when you get a pinched nerve from a problem involving the disc or the facet, it's not the bone spur that's at the disc or facet that's pinching the nerve. It's the herniated disc or the facet capsule hypertrophy or synovial. It's called synovial hypertrophy. That's what's causing the pinched nerve, not the bone spur. So the bone spurs are just there. Now, the reason why everybody talks about bone spurs is that over the last 30 years, doctors have told patients, hey, you've got a problem in your neck, you've got a herniated disc. And then you get chiropractors that tell patients, if you do chiropractic treatment for 3 months or 6 months, your disc herniation will go away with chiropractic. So then the surgeons look at the patient and go, that's not really true. Okay, well then let's say you've got bone spurs. Well, bone spurs aren't going to go away with chiropractic. So it's basically a ploy by doctors to emphasize bone spurs in people's spines because they know the patient doesn't have a way out of saying, oh, well, you know, the bone spur will go away on its own. No, they don't. Bone spurs don't go away, neither the herniations. So the truth is that the bone spurs aren't really the problem, but either the surgeons don't know that or the rest of the medical community doesn't know that, which is probably the case, or they know that and they're just using that as a way to get you to do the surgery because you know the bone spur just won't go away on its own. So the truth is, I rarely ever have to take bone spurs out. They're never the cause of the pinched nerve. Never.
Next question comes from Teresa on Facebook, and they ask, can kyphosis of the cervical spine cause pain in the hands and arm?
So Teresa, can kyphosis of the cervical spine cause pain in the hands and arm? No. Kyphosis does not cause pain in the hands and arm. The reason why most people have kyphosis in their cervical spine is because they're having neck pain or a pinched nerve, and that's causing their muscles in their neck to spasm. And when you get spasming of your muscles, it changes the alignment of your spine in the MRI, and it makes it look like you have kyphosis. But it's really mostly usually due to muscle spasms. You get rid of the pain source in the spine, you get rid of the muscle spasms, and you get rid of the kyphosis. So kyphosis itself would not cause those symptoms. I would recommend you get the MRI review done.
Next question comes from Darren on YouTube asking, would you correct a scoliosis curve greater than 50%?
So Darren is asking a great question. Would I recommend surgery and correct a scoliosis curve when it's greater than 50%? Yeah, I gotta say, Darren, that's a pretty big curve. And the answer is going to be here. Here's how I'll determine the answer. How old is the patient? Somebody who's young, you know, in their 20s, 30s, teens, 20s, 30s, 40s, I probably would correct the curve and I would fuse it. Somebody who's like 80 or 90 and they have a 40-degree scoliosis, I would tell them that's too big of a surgery. It's just not worth it. The second thing I want to know besides their age is the curve doing anything? Like, does it affect them with their balance, their gait, their activities, their work? How is it impacting their life? If it's not impacting their life very much, I would not recommend that surgery. Okay, but again, if you're young, in your teens or 20s, early 30s, and you've got a 50-degree curve, then I would probably recommend fixing it because it's just going to get worse over time. And it is going to start impacting their quality of life for the patient. So the answer to your question depends on the age of the patient and the effect that the curve is having on their quality of life. Sorry, I can't give you a better answer.
Next question comes from Teresa once more on Facebook, and they ask, what is degenerative disc disease L4-5 with vacuum disc phenomenon?
Yeah, Teresa, so what is degenerative disc disease L4-5 with vacuum disc phenomena? So let me show you what that is. Basically, your disc is a cushion between two bones, right? So here's the L4-5 disc right there. The disc has two parts. It's got a wall called the annulus, which is made of collagen, and it's got a jelly in the center made out of proteoglycans called the nucleus. If you get a tear in your wall, then the jelly over time will seep into the tear. It'll create inflammation. The inflammation will then destroy your entire disc over years of inflammation. That will cause your disc to collapse. It'll cause bone to sit on bone, and then it'll cause the bones to rub on each other. You'll get irregularities of the bony surfaces called modic changes. You'll get pitting. You'll get hypertrophy of tissues. Long story short, in the end, your disc is completely gone. It's just annihilated by the inflammation going on in there. And you actually can get a situation where you have negative pressure, where you have basically space, you know, inside your disc, a vacuum. Space is a vacuum. It has no air, right? If you go into space, you can't breathe. There's no oxygen, no nitrogen, nothing. It's devoid of substance, except for, of course, gamma particles and alpha particles and things like that. But you can't breathe those things. So space is a vacuum, and if you have some air and you expose it to space, it'll suck out of the canister and it'll diffuse, right? It goes along its concentration gradient. So in the disc, when you get rid of all the substance and you pull the bones apart and with certain movements, it actually creates a sucking. And so you have this thing we call vacuum space phenomena. It's basically an air pocket in the middle of the disc, and it only happens in really degenerated discs. That's not important. That's not causing a problem for you. If you're having pain, it's coming from your annular tear at that disc, which I can fix with the laser surgery that you just watched.
Next question comes from Darren on YouTube once more, and they asked, can patients jog/run without pain after having a procedure?
So Darren, can patients jog or run or be active after having my surgery? 100%. Folks, it's so fascinating. By the way, I love your questions because they really help me understand the way people think about these issues. And honestly, I would not think the way you guys think because, of course, my mind has been trained as a neurosurgeon to think about him as a neurosurgeon, not as a person suffering with these issues. But I listen to my patients, I listen to the questions. It gives me insight into what you all are thinking. And it makes me recognize what's important to you, the patient. And so getting back to normal activities is important to you. Normal activities, not limited. Of course, that's the whole point of our surgery. We do this surgery to give people back their normal life, not a restricted life, a normal life. So the answer is yes, you can go back to all your activities, even jiu-jitsu, even, Muay Thai fighting, whatever you want, football, rugby, gymnastics. But you've got to let the disc heal for a long enough period of time after surgery. And this is where most people fail. They don't allow, not most people, but when we have a failure, it's because they didn't allow the disc to heal. Our re-herniation rate is 1%. That means 1 out of every 100 surgeries you're watching me do, they re-herniate. And they always re-herniate because they don't follow the rules. I give them restrictions, don't bend at the waist, pick anything up from the ground. They don't listen to me, they're feeling great, there's no pain, they think they're healed 2 weeks later, so they go out and they lift mulch bags and they're gardening or whatever, and they pop and then they re-herniate. So, to avoid a re-herniation and have a successful surgery long term, you need to let the disc heal. So there are restrictions for 12 months after your surgery. Running and jogging are not restrictions. You can start doing jogging in 2 weeks. You can start doing running in, I would say, 3 to 6 months. Depends on how bad your tear is at the end of the surgery. So just everybody's a little different, but 100% everybody can go back to normal activities after the surgery.
And then last but not least, another question from Teresa, once more on Facebook, asking, what is the address I could send my MRI to be evaluated?
Teresa, what's the address you can send your MRI to be evaluated? So the answer is don't just send your MRI. You must use our online form. You must fill it out. If you don't fill out the online form, we will not review your MRI. We get lots of people sending their MRIs to us, and we're like, who is this? Bert Sanders? We don't know. So you got to do the online form first, and then you can physically send your MRI by UPS or FedEx. The instructions are there on the online form. We put the mailing instructions after you fill out the form for a reason, because we don't want you to see where to send it until you filled out the form. That way we have some data and we have your MRI, and when I do my MRI review with you on the Zoom, I can see where your pain is, I can see where it goes, I could look at your MRI, I could read your report, and I've got everything I need usually to make a diagnosis and come up with a treatment. So please do it the right way. Use our website, use the MRI review form, fill it out. It'll give you instructions on how to send us your MRI, and I look forward to figuring out what's wrong and helping you. All done. We got another surgery shortly. I'm going to give Henry a break, and we'll be back. Our next surgery that I'm doing, you're not going to be able to see but it's a Duke plasma rhizotomy. This patient has pain in her thoracic, and we're doing it in operating room number 2, okay? Not number 3. Our operating room for broadcasting is number 3. The operating room number 2 doesn't have the equipment for broadcasting, and this patient has 2 facet joints in her thoracic, T6, 7, 7, 8 on the left side. They're horribly painful. I'm going to go in there and zap the pain nerve using the Duke plasma rhizotomy technique. We're not broadcasting because it's in a room we can't broadcast. So the next surgery, and by the way, she's from North Carolina. The surgery you'll all be able to see next is a patient from California, and folks, you got to check out, I'm sorry, I hate to do this, but you got to see his back. He went to one of our competition. I don't recommend going there. I think they're closed down anyway. The state of Florida closed them down. He went to the Bonati Spine Institute. He went there and he had many back surgeries. He's still in horrible pain. And wait till you see his back. You're going to see it. He's literally, it looks like Freddy Krueger operated on his back. If you all know who Freddy Krueger is. Long story short, he finally found us. He's here to get fixed. He's from here. He's from California. He's here with his mom. We're doing L3-4, L4-5 on him. And I think he's going to do fantastic with the Duke laser disc repair. So I'll see you back in about 30 minutes.